been involved with PPEC and then P2, which hopefully many of you guys are involved in. If not, you can reach out, but it's our international PEM POCUS organization, essentially. And have been a attending physician at UMass Chan Medical School going on 5 years now, but trained kind of up and down the East Coast of the United States, Boston, New York, Philadelphia. And Pat Bonson here is our ultrasound fellow. We've been working together now 4 years, kind of crazy.
The whole time I've been here, actually.
So he did his EM residency here and is currently an ultrasound fellow. We don't have any disclosures, unfortunately, to disclose today. Our main goals for today are really to go over, pediatric lung POCUS technique, talk about some pearls and pitfalls. We have some cases that we hope you'll find interesting. If we have time, we kind of have a proposed algorithm that we'd love to kind of propose and chat about. And again, much in the way of PPEC, we welcome kind of interruptions or use of the chat. Makes these kind of talks far more interesting. So without further ado, I'm going to pass this off to my friend, Pat.
Hey, nice to meet you all. How's the presentation looking? Is it going through okay at this point?
Thumbs up.
Thumbs up?
Yeah, all good.
Very good. I added a few slides just because we're, pleasure to chat with you all from across the ocean here, but just to let you know who we are and where we are. I'm assuming you probably haven't been to Worcester, Mass before, but we're sort of located right here in the center of the state, kind of the largest catchment area for the hospitals in the center of Massachusetts. Second largest city in New England, which sounds funny until you remember New York actually isn't in New England. So we're right behind Boston, fairly large. I was trying to think of any and all. I know nothing about the UK, self-admittedly, but I added this just to, I was curious what connections we might have to you all across the pond. There's actually a number of sister cities we share with you, all uncreatively named, basically the same, Mansfield after Mansfield, Andover after Andover. Of course, we share a sister city with Worcester and Worcester in the UK, but never been myself, haven't had the pleasure yet, but perhaps sometime in the future. About our hospital system itself. So UMass is fairly large. We incorporate about 9 hospitals. We have 5 main campuses. Now, this is a PEM POCUS. So our only real dedicated pediatric hospital is here in Worcester. It's a level 1 pediatric trauma center, 11 dedicated PEM faculty, 2 current fellows, and then a department that has about 20 beds, 6 of which are vertical triage, and then a dedicated pediatric psych annex. Our campus itself looks like this lovely picture here, and this, slightly more cloudy picture here where our actual emergency department is. Our machines, so all the pictures you see today are recorded on these GE Venue machines that we have. There's 5 total kicking around the department. We actually have a new Philips machine for the pediatric version, but all the images you should see here, with the exception of 1 or 2, will be taken on the GE Venue. We use a software called Synchronicity to upload all of our images. And so for part of my talk today, what I was hoping to discuss is what we expect of the pediatric EM fellows, the pediatric residents, and the emergency medicine residents who are all going through the department. What do we look for on pediatric lung ultrasound? What do we find useful in the emergency medicine department? How to identify it? And then the most important part, how is it changing management during the flow through of these pediatric patients, and how it can change your flow through? So this is a typical example on the side of what a resident or a fellow or myself or anyone is going to see when they do a lung ultrasound on a pediatric patient. They have 2 different studies that they can go through. One is dedicated just for pneumothorax, and one kind of is a catch-all for everything else. The reason we do that is because we like to limit 2 views for our, we suggest 2 views for our pneumothorax study. And with our other studies, it's going to be more comprehensive, utilizing views in 4 quadrants of the chest, sometimes additional views on the back or on the lower sides. For these spreadsheets, residents, fellows, attendings, They fill out what their findings are, and then all of our images are sent to the system where they're then overread by myself, one of the ultrasound fellows, or by the pediatric or by the adult ultrasound faculty. So all of our images are overread by someone who is specifically ultrasound trained, and that way it can enter the chart having this overread. As far as the sites themselves, so now kind of transitioning more into the anatomy of the patient and the typical normal ultrasound part of the talk, we recommend using this sort of 4-quadrant, sometimes 6-quadrant, but 4-quadrant view, including the mid axillary region, sort of that anterior lateral chest region, and then regions 5 and 6 on the patient's back. Now, this is, not the typical pediatric patient. For our smaller pediatric patients, sometimes I'll utilize this sort of 3-quadrant sort of approach, where you'll have this anterior, axillary, posterior. It all just depends on how much lung you're dealing with on the pediatric patient. The reason I mention this is on some of these slides, you're going to be seeing this sort of diagram demonstrating those 4 regions. And so just to localize yourself to where we are on the chest. So starting just from the bottom there, typical anatomy. This is actually one of the newer machines, but typical lung anatomy on a pediatric patient. You first have our linear probe going through chest wall, the ribs, the pleural line, those posterior acoustic shadowing from the ribs, and then some normal artifacts, the A lines, that sort of reverberation artifact between those waves in that pleural line. This is a normal lung. Here it is in wonderful motion. Hopefully it's coming through clear, but a normal lung. Talking about sometimes normal, sometimes abnormal findings that we're going to see in a lot of these pictures. I just wanted to quickly mention B lines. A lot of different terms. Sometimes you'll hear like rocket tails, or what did someone say? Well, yeah, rocket lines, or
Comet tails.
Yeah, comet tails and rocket something. But these are all in a host of a family of artifacts that can develop into these things called B lines, these sort of like bell bottom spewing artifacts that go down into the lungs. Sometimes can be normal. Oftentimes when you see more than 3 per field can be abnormal. And we're going to see them later on in our presentation to discuss. What I've used is these sort of case studies that we had in our department over the past couple of years to sort of launch off into the abnormal lung ultrasound findings. So I want you to put yourself in the frame of mind of this is a patient coming into your emergency department, and how am I going to use ultrasound to either enhance or change their care? So as our first case, we have a 3-year-old female, no significant past medical history. She's vaccinated, 6 days of cough, 4 days of fever. And she actually had come in on day 1 of her symptoms, had a diagnosis of a viral upper respiratory infection, looked great, was sent home, but now is coming back with worsening work of breathing. So chief complaint there of a cough. Talking about her exam briefly. So she has some tachycardia on her vitals, but no fever. She looks well appearing generally, but does have some tachypnea, some decreased air movement, and some rails to the lung bases, along with the tachycardia, which we mentioned before. No acute distress. This patient actually ended up getting a X-ray before their ultrasound, and I'm going to talk about why that's important here. But this was their X-ray. We can see an obvious consolidation. I don't know if my cursor's coming up here, but obvious consolidation to that right lung base. And this is the read. The right lower lobe and lingular consolidations consistent with multifocal pneumonia. Great. The reason I'm talking about them in this ultrasound discussion is they then had their ultrasound after the fact. Now, this is the normal lung, the base of the left lung. We see that pleural lining. We see 1 or 2 little comet tails there, but no large effusion, and then what looks to be spleen coming in and out of the screen. Going over to the affected lung side, so now we're sort of in between these views that we talked about before, the 3R and the 4R views. We see, again, some of these B lines initially at the start of this clip. And then as we go down, we start to see something more abnormal, something that catches our eye more. What we have here is a demonstration of both static and dynamic, 1 or 2 dynamic air bronchograms. And so I'm going to pause the clip right here. What we can see is this sort of hyperechoic or more hyperechoic texture of the lung, sometimes called hepatitization, or sort of like a liver-like appearance of that consolidated lung, along with these air bubbles. And if I put it in motion, we can see just about 1 or 2. I think there's another clip of this sort of what we call a dynamic air bronchogram, movement of these air bubbles through these small bronchioles at the base of the right lung. The reason I mentioned this ultrasound in particular on this patient that had that X-ray is there's an obvious effusion right here at the lung base. So I'm going to try to highlight that here. Let's see if we can get it. right about, come forward, there we are. So, a millimeter, 2 millimeters or so of this, actually more than that, sorry, these are individual centimeters, so several millimeters here of an effusion at the right lung base. Not seen on the X-ray, was seen on the ultrasound, and we're going to harp on that a little bit more in a moment. These air bronchograms, if you haven't seen them before, they were not initially a finding on ultrasound. They were a description of a finding on an X-ray. Now, on an X-ray, they would look something like this. You're now seeing air-filled bronchioles in a consolidated lung that you would not see otherwise, right? Because the whole thing's filled with air. It's similar in ultrasound where you don't normally see the air-filled bronchioles. They're there, but we don't have the ultrasound waves that are able to pass through the parenchyma to them. Now with the consolidated tissue, you're able to visualize them. The reason I differentiate between the dynamic and the static air bronchograms, that sort of bubbling movement versus the static ones, it's somewhat believed that those dynamic, that air flowing through the bronchioles, can be slightly more specific for pneumonia specifically. Whereas a static air bronchogram traditionally is thought of as more of a consolidation from basically anything. You can have proximal plugging, mucus plugging, a mass, anything that can cause that sort of atelectasis and consolidation. So here in this patient, we see both dynamic and static, very highly specific, highly sensitive for that pneumonia. The thing that changed is that we're able to see that effusion at the lung base, the simple effusion that we weren't able to see before. Let's talk about the disposition, and then I'm going to harp a little bit more on why that ultrasound plays a role in this patient's care as opposed to just the X-ray. So the patient themselves, they had fluid resuscitation. They got started on their antibiotics. They were admitted to the pediatric floor and then ultimately did well. They ended up going home on amoxicillin once they had improvement of their tachypnea. Here I've pulled one of the more common pathways in the US, CHOP pathway, to discuss pediatric pneumonia. As part of this workup, as we go through this sort of community-acquired workup for a pediatric pneumonia, we see that they describe the effusion on chest X-ray and how this might be able to change management. And so if we sort of go down into this area a little bit more, we see that depending on the size of the effusion and depending on the appearance of the effusion, you can actually have a pretty large change in the patient's disposition, with findings of empyema being a reason to talk to general surgery, possibly putting in a chest tube. Now, most of the times that these are large, you will see them on X-ray, but X-ray is not, what I'm trying to harp on is X-ray is not the imaging modality for effusion. That is ultrasound. In fact, they specifically mention, quote unquote, ultrasound is the recommended initial study for most patients to evaluate the presence of effusion. And this is a perfect case of that. This is a patient who had a clear effusion. It looked simple appearance, not seen on the X-ray. Now, in this particular case, it was a small enough effusion where it did not need a chest tube or drainage. But it's not, hard to think of a case where you would have one that would be not seen on X-ray, seen on ultrasound, and we'll talk about those cases in just a moment. Let's talk about another case. All right.
Any questions or thoughts before we move on?
There's nothing in the chat, but I'll keep an eye. Any questions, guys, feel free to just jump in.
Yeah, thank you.
So different patient here, 6-year-old male. This patient is autistic, also up to date on vaccines, 10 days now of upper respiratory virus symptoms, 7 days of fever, quite a long time there. Let's talk a little bit more about their symptoms. Nausea, vomiting, diarrhea for 10 days. They had a negative respiratory viral panel and a fever, fairly high, 105 at home. They also had been come into the department, diagnosis of the biogastro 5 days prior to arrival, continued fever and a worsening cough. Their vitals actually look better than that first patient, right? So no fever, no tachycardia, but they are ill appearing. They do have tachypnea. They also have abnormal right-sided lung sounds, unremarkable cardiac exam, and generalized tenderness on their abdominal exam, a fairly difficult abdominal exam I remember hearing. Let's take a look. Now, this patient had the opposite. They had their lung ultrasound first. So as we go through this 1R, so the anterior, probably, second or third rib space region here, we see that nice sliding of the pleural line. We have our chest wall musculature looking intact. We see maybe 1 or 2 A lines flickering in and out, but nothing abnormal, right? None of that consolidation that we saw before. And then we start to come down onto the right side. And immediately there's something that should stand out here. It almost looks like a step off, like you're looking at a fracture pattern almost, right? You have this hyperechoic pleural line and then this sudden sharp decrease and then movement of another hyperechoic line further down. So not normal, and this is the start of something called a subpleural consolidation, otherwise known as a shred sign. Let's take a look and interrogate that region just a little bit further. Okay, now we're thoroughly into an abnormal territory. And this is sort of a mixture of two of those abnormal findings. We have both the subpleural consolidation mixed with a rib shadow, but also those air bronchograms that we were seeing before. Just a little bit more than that prior patient. The thing that we don't have on this patient is the presence of an effusion. I'm going to stop and just talk about that. It's just like the air bronchograms, we're going to talk about this abnormal ultrasound finding. So this is a subpleural consolidation. It's also called a shred sign. You can appreciate that it takes on this sort of shredded appearance underneath this consolidation in the pleural lining. It's static. It does not shift. When the patient breathes in and out, it should move along with the sliding of the lung. What it's actually demonstrating is an area of consolidated lung that the ultrasound is able to pass through easily. Right, it has some amount of fluid, it has some amount of consolidation or atelectasis that allow those ultrasound waves to penetrate through. And as they leave that area of consolidation, they're now entering, I'm not going to say healthy, but more air-filled lung territory, giving you this sort of air pattern underneath it, this shred sign. Some things can throw you off with this. Now, it is when you have this very typical appearance of a shredded appearance, when it's highly irregular, when it's surrounded by B lines, that's very sensitive and specific, both for an infectious or consolidation pattern. There are other forms of subpleural consolidations that can be from things like a pulmonary embolism, for example, a wedge infarct. It takes on a slightly different pattern where you will not have that finding of edema around it, a much sharper edge, just a different sign. But to say the least, this type of appearance here on the screen would be more concerning for things like a atelectasis or a pneumonia, as in this patient. Let's go down to the lung base of this patient now. Now, they have a much more clear dynamic air bronchogram. We can see as the patient is inhaling that sort of bubbling appearance at the lung base without the presence, perhaps a trace, but not a large effusion here. Now, a lot of rib shadow on this particular view, but dynamic air bronchograms, just as the first patient. Then they get the X-ray. And the reason I bring this up is the X-ray, as in the first one, it's still not totally clear about the effusion. In fact, this one kind of errs on the other side. So blunting of the right costophrenic angle may be due to a small right pleural effusion, but it's unclear, right? And now that we've interrogated it with the ultrasound, we can say that there's no pleural effusion. The patient is going to be treated for pneumonia without pleural effusion appropriately. So they were started on antibiotics, ceftriaxone, and changed to ampicillin, and then went on to the hospital service. Improvement following chest X-ray on hospital day 2 and discharge on day 3. So they did quite well. Okay. So we've been harping on infectious symptoms, pneumonia, subpleural consolidations, B lines, hepatization. And we can just check the chat there before we dive in. So I'm looking good. So case 3, another 6-year-old male. This patient's also autistic. They presented for 3 weeks of ongoing fever. They had prior diagnosis of strep throat. That started on day 2. They had their amoxicillin course. It was started and finished appropriately. Then they had a diagnosis of flu on day 7, so 5 days after they started those antibiotics. They received Tamiflu. So patient had quite a prolonged course. On day 14, they were diagnosed with a pneumonia. I believe that was on an X-ray, if I recall, treated with amoxicillin and then transitioned to azithromycin. They're now presenting again on, I'm sorry, not day 21, but rather day 22. They had improved with the amox and the azithro and then began to worsen again, now with the fever to 103, went to their PCP, had a white blood count elevation, and had a left lung effusion, again diagnosed on X-ray. Here's their vitals. Looking great. General, alert, active. They have decreased left lung sounds.
Dave, those vitals scare you, right?
That's right.
Yep.
Stone cold normal. Cardiac, unremarkable. No tachycardia. Skin peeling on the hands and the feet. This patient had outpatient workup with X-rays, but their first imaging study, as I recall, in the ED was ultrasound. We're starting on the left side, on that decreased air movement side. So this is a little bit unclear. It's a bit dark. We're seeing what looks like perhaps you're looking at lung tissue here, but it doesn't look normal, right? This should immediately raise red flags. I'm not seeing that bright white pleural lining that I'm used to seeing, that quote unquote like ants on a log appearance as the patient breathes. I'm not seeing normal artifacts. I'm not seeing A lines, and I'm not seeing any B lines. I'm not seeing the rocket tails, comet tails. Something is amiss. Let's keep going down. Okay, now as we start to get into this little brighter region with our ultrasound, we're starting to see this sort of honeycomb appearance and then flickers of movement. And when you're first seeing this, especially with the priming of the last cases, you might be tempted to think, oh, maybe I'm looking at hepatitization again. I'm looking at a consolidated lung, and perhaps this movement might be something like an air bronchogram. This is, what I had first thought. Let's keep going. Okay, we've now adjusted the gain. The patient is appropriately gained. This is clearly abnormal. What we're seeing here is loculations, septations of an empyema. This is not lung parenchyma that we're seeing ourselves, seeing here, but actually a somewhat infected empyema with this sort of fibrinous tissue moving throughout, but not hepatitization of the lung, not normal lung parenchyma, rather outside the normal lung. In fact, this is probably normal lung, sort of tucked away down here. Very stringy appearance. Interesting movement, almost looks like parasitic in nature. I'd like to compare this to what would be like something more of a simple effusion. So this was another patient we had whose case is not discussed here, but appreciate the appearance of this fluid. I've paused it here, but the appearance of the fluid here on the right side of the screen versus the one here, fairly striking, right? Now, even here, it's not purely hypoechogenic. It's not purely black. There might be little, bits of debris, but a clear difference between this complex empyema versus a simple lung effusion. This, in this particular case, I believe, was an exudative lung effusion in group A strep. This is the patient's X-ray. So they had had one previously. They had one now. Left lower lung consolidation with collapse of pneumonia with moderate size. They actually call it a loculated left pleural effusion here on X-ray, which, I mean, I am not a radiologist. I don't know how they can see the loculations on X-ray, but they're spot on. Mild interstitial edema.
Maybe they took a look at our POCUS.
That's right. That's right. They are safe to the chart, so perhaps. Let's talk about how this patient fared. So in this particular case, going through that pathway we worked through before, a complex pneumonia with empyema, with loculation. Surgery was consulted. They have gross white count elevations despite their wonderful vitals. They were started on antibiotics, but ultimately had a chest tube placed. Left side, they had 3 days of TPA inserted through that chest tube, and the tube itself was removed on day 7. Patient was discharged on day 8. Did wonderfully. I've included just a few pictures of that chest tube placement and then the gradual improvement of the patient's lung reinflation. They did quite well. They actually had a little bit of a reaccumulation of that fluid right on the X-ray before they left, but there are no ultrasounds on the inpatient side, so they didn't have another one for me to compare it to before they left, unfortunately. I bring this slide up again just to mention we're going down the right side of this pathway now with a clear evidence of empyema on the ultrasound. If I was alone at night, I probably would have read that X-ray as having an effusion, but I wouldn't know if it's loculated or not, and that's where ultrasound would come into play.
Just to jump in, I'd love anyone's kind of reaction. I mean, this is one of my, very stark cases of like the kid was better, right, and then came in with stone cold vitals and that lung ultrasound. And I just love looking at those clips every time. But if anyone had any reactions or thoughts or impressions or.
Yeah, I've got some reactions, guys. That's a brilliant case. All case really, really good. Great images. That one was fantastic, wasn't it? Because that is what when I teach, I kind of talk about, the wonderful world of pediatrics that we live in, that we all love. The child who can walk in looking terrible with a minor illness, and the kid who walks in with, as you say, totally normal vitals with something really serious going on, something life-threatening, really. So that was a great illustration, I think, of the detail that lung POCUS can provide relative to x-rays, can be easily repeated hourly if needs be. While the child goes to the ward, they might deteriorate with an increased oxygen requirement, that sort of a thing. So I think that was really powerful. Do you think in the first image you were seeing the same thing, a degree of just, obviously it was hypoechoic, a degree of loculation there, or there's something I like to do, which is to put the M mode cursor through and check for the sinusoidal sign, see if I get that flow. Sometimes if there's something very, very dark on the screen, someone's not sure exactly what it is. Is it definitively fluid? Is it part of another viscera? That's been really helpful to see that little kind of waves on the ocean sign. So what do you think you're seeing there?
I think, I would back up, but I'm afraid I'm going to ruin my slideshow if I try to do so. I think we were seeing the empyema in the first slide, and I believe, Dr. Binder, you may have been the operator for this one, but as we went down, I think there was a few adjustments with like the placement and the brightness of the probe that helped that empyema really show up. But I think we were seeing it from image 1 down.
I don't know that I was in a much different place. It was just, really the gain really kind of elucidated that finding. It's an interesting point about the use of M mode. Like obviously you can see the movement in whatever it was, clip 3 and clip 4. But is there some movement there that's more subtle and kind of hidden, if you will?
Yeah, there's a really interesting question in the chat. Someone's asked, do you have any images of necrotizing pneumonia? It's your talk, so I'll let you guys answer that. But I know what my sort of response to that would be. That's a really interesting concept, and I'm sure you'll agree with me in saying not one that we utilize as a term in POCUS language necessarily. And I think even the radiological description of necrotizing pneumonia isn't a really fixed one. We're talking about kind of cavitation and maybe abscess and all of that type of stuff, staph versus strep versus whatever. That's really interesting, isn't it? Because I guess the person's touching on a point of what would the progression be into really horrible looking pneumonia, whether or not we ever use that term. I know it's one that I don't. How about, I don't know about you guys?
That was gonna be my first reaction, is I don't, typically kind of use that phrase, not for any reason really other than what you're alluding to. Mainly because I just don't need to, right? Like I just have to figure out their disposition and, who to kind of get involved in the case. I mean, for me, that's almost like a pathologic diagnosis, right? Like if they have to do a VATS or something like that. The other thing I'll mention just with lung ultrasound generally is in like the third world, the number of people walking around with fulminant TB and just like insane lung findings, probably far more impressive than even that third case, is kind of a remarkable thing. Literally people walking around with, fibrotic loculations and all kinds of things. So, my guess is you guys are probably closer to on par with us in terms of, some of those kind of demographical type things, but just to bear that in mind.
Yeah, well, I'll chip in with just one point, sorry. And we did have this really good case of a sort of a lung abscess a while back, and it was really interesting because kids can have this kind of strange quirk where they can get this thing called a round pneumonia. I don't know if anyone's familiar with that from the pediatric exams, whereby it may not necessarily abut the pleura based on the architecture of the bronchioles in a child versus an adult, and it's quite complex if you read about how it occurs. But I'm not an expert. But yeah, this was sort of just a circular kind of almost abscess looking thing right in the center of the lung, and I think it probably doesn't show in the same way initially until it's established. So if you're talking about kind of abscess formation and how that would look, we had a case once, and we were teaching on a course with a radiologist who's really supportive of POCUS in this region, good guy, and he was like, yeah, that's a kind of an abscess from around pneumonia, and it looked very different. It looked very different to your normal consolidated lung.
Yeah. I always felt we need a worldwide just Dropbox for interesting scans. POCUS community can just create one library of all the favorites. But no, I'm afraid I don't have any images of that. I feel like everyone has their own private collections through some way of their favorite ultrasounds. So these are kind of cherry picked just from the one we had upstairs. But yeah, these are in talking about the cases actually themselves. These are cherry picked to cover what we expect of all of our faculty and all of our residents here. And this is sort of, this last case we'll touch on, basically the last emergent finding that we expect of everyone coming through the department here. So older patient, 16-year-old male, we're back in the ED. No pertinent past medical history. He had sudden onset left-sided chest wall pain. Now, of course, we can anchor pretty heavily here given the nature of my talk, but sudden onset left-sided chest wall pain with some inspiration, but it's been improving since it began. He has no shortness of breath, no increased work of breathing at the bedside. He says his pain is almost resolved. Here are his vitals, suspiciously normal. This was his initial exam. He had normal effort, non-labored work of breathing. Interestingly, no mention on the lung sounds. I'll note on this initial exam, which is perhaps not the best. Cardiac regular cardiac exam. Chest X-ray here. You flash through it. It's a busy department. You have to keep going. You have to see patients, and you have no. This is a fairly common thing. I'm not sure if it's the case in the UK, but it's fairly common, especially in the community shops here, where you will read your own X-rays overnight, or in some cases you will have someone, a resident read overnight. So in this particular case, it's both in a, this case was an adult emergency medicine physician along with a radiology resident who read the X-rays. Both said negative. Obviously, based on how I'm talking to you, that it was not negative. But is this? I'm just curious. Is this something that you all have to do? I'm not sure what your practice patterns are. Do you read? Are you responsible for your own X-rays at some point during your shifts? At some point during your night?
Yeah, I'm sure I'm answering for everyone in the UK on behalf of everyone. Yeah, it falls within our remit, certainly, with the option to get it expert reported, if it's something more complex. Yeah, same would go for, head CTs. But again, you're reaching out for your abdominal CTs and stuff like MRIs, stuff like that.
Or, MRI, yeah, oh boy. You have to be very abnormal for me to pick up anything on an MRI. So here, what was missed, not to belabor the point, there is a small, not too small to moderate left-sided pneumothorax. Here is the lung parenchyma line here that was missed. The patient looked great. He ended up going home. I'm not going to harp on this too much, but there's a lot, you probably are aware of this, there's a lot of suggestions, especially in the setting of trauma, but even outside that setting, of ultrasound being superior for the findings of pneumothorax on both pediatric and on adult patients. These stats here are pulled from a study back in 2015. They are in the setting of trauma, so somewhat tangentially useful, but for the sensitivity and specificity of ultrasound over X-rays for pneumothorax specifically. So this is, if there's anything that I would love to see, the residents here and everyone around the world using ultrasound for pneumothorax is certainly one of them. We're jumping straight to the ultrasound. Now, an ultrasound obviously was not performed this first time. The patient was actually discharged home. Now, they did not debilitate. They did not come back in a worse condition. They had a overread by an attending radiologist in the morning that picked up the pneumothorax. The patient got called back, and this was their starting ultrasound here. You're talking about that sort of like M mode usage. Here we are in between those two rib spaces. Now, if you're not too familiar with M mode here, it tracks movement through this line over the course of time. So time running along our x-axis here. As things would enter in and out of this slice, you'll start to see them appear and disappear on the screen. Things that don't move, for example, this pleural lining, right about 2 centimeters or so, straight line meaning no movement. Now with this sort of, we call it a barcode sign, or sort of lines running throughout the time axis, we see that there's no movement of the lung parenchyma. This is grossly abnormal, consistent with the pneumothorax. Great. You had a repeat X-ray now, very helpfully labeled by our radiologists, I'll mention, with an arrow sign, classic. The patient is still well appearing. However, their pneumothorax had grown slightly, and so they ended up with a left-sided pigtail. It was performed in the ED first. Went upstairs, discharged on hospital day 3, and did quite well on their 2-week follow-up. That concludes all the cases I had for him. I'm going to turn it over to Dr. Bender here.
So we're entering more of the conversational portion of the talk, I hope. And if anyone other than Dave is willing to kind of jump in, that'd be lovely. So, I mean, this for me is chest pain in a child, must be POCUS, right? That's our that's our prime kind of target, and we talk about that in PPEC quite a bit. Does anyone have any other kind of reflections before I wax poetic about lung POCUS and chest POCUS?
I just wanted to ask, thanks for the talk, by the way. Your cases are really, really, really good at demonstrating all the different signs we can find on POCUS. What kind of training or accreditation pathway do your trainees and residents have to go through when they go through your department in terms of, being competent? I know you can't see me, but I'm doing inverted fingers to carry out these scans. I know you mentioned that all your scans kind of get overlooked by someone who's considered an expert in ultrasound, but just from our department where we don't have the same skill set as you do, just in terms of we were trying to train up our staff, what kind of pathway do you have?
Yeah. And I've learned this from Dave, that the terminology and kind of ascension of, expertise has kind of different terminology over here, which may complicate my answer for you guys. But I think one major distinction is whether you come up through emergency medicine or pediatrics, right? So the way kind of things work here is you go to medical school, and then residency is that first step. And people in me and Patrick's world kind of take one of two paths. So if you enter into emergency medicine, that's a 3 or 4 year residency. And as part of that residency, the trainees become very adept at point of care ultrasound. I would go so far as to say experts, essentially, in, lung included, but, cardiac, shock, kind of the standbys, right? If you go through pediatrics, it's a bit more complicated. So we're actually working on a white paper through P2 about what training pediatric residents should get in POCUS. Right now, the answer is essentially none, unless someone like me makes it a pet project, right? So the assumption is none. And then they might go into fellowship in PEM, which is really where they get their ultrasound training. So, they'd be under the tutelage of, an ultrasound director, ideally, like myself, and over 3 years kind of acquire the skills and have a prerequisite number of scans. Nigel, more to your point, the prerequisites and the tracking and the credentialing are far more established in EM. In PEM, it ultimately ends up becoming this type of deal where if we have a graduating fellow, it's basically up to me to say, they're up to snuff or they're not. There's no kind of formal credentialing process. Does that answer your question?
Yeah, I mean, it sounds quite similar to the training pathway here. So our EM trained colleagues do something similar to what you were describing in terms of kind of basic ultrasound for shock AAA and stuff is built into the curriculum, whereas in the pediatrics, where I come from, it's very much not. So It does sound pretty similar. We don't have as much fellowship opportunities as you guys seem to either, is the other issue.
Yeah. I guess the other point too is, right, the younger generation is far more facile, whereas I have colleagues who, either my generation or slightly older who, do not do POCUS, for essentially. And so the spectrum amongst attendings is actually far wider than amongst trainees. There's some basics, fast, EFAST that everyone, I cringe, but should be kind of capable of. But, the variation is still massive. The other point too, just before I kind of move on to this next bit, is to Patrick's point about, the ability of ultrasound to pick up pneumothorax. So I trained in an adult center, and it actually got to the point where they were trying to figure out workflows and algorithms for the fact that they were picking up so many more pneumothorax Cs that they weren't seeing on X-ray, right? So the trauma surgeons were getting upset that they kept finding these small pneumothoraces in, blunt trauma, and being like, what do you want us to do with these, essentially, and not like, are we going to chest CT all these people? So it's so definitively better, I guess, is the point I'm trying to make. Okay. And then I guess, these are just more kind of thought-provoking questions, but and we've talked about this in PPEC quite a bit, but I think the ultrasound's ability to image lung is improving dramatically, right? So, I always have this internal debate, are we seeing sicker patients? Are we seeing more interesting pathology? Or is it that the software behind these machines is improving its capabilities? So I'll pause there and see if anyone has any thoughts, I guess.
Just in relation, you're just asking Zach in relation to like, what are the limitations, or just commenting on how
I'm just
reliable
picturing,
it is?
like, I started my training in 2013, and I just remember like the ability to pick up anything beyond like very overt findings, I feel like was not there. And now, we're picking up like those fibrinous loculations, and like, we're not squinting to decide if it's a pneumothorax. It's just the quality of image has improved dramatically, I've found.
Yeah, I agree. And I think a big thing why I'm so passionate about kind of these sort of groups and, teaching all of that is because in PEDS and PEM, it is a small group. So it's not just the imaging technologies that have progressed, it's the collective knowledge of people, like, we're putting our heads together, we're sharing cases, we're doing little studies. And I think we have the patient group who are going to, by a mile, benefit the most from the use of ultrasound. I always call it a match made in heaven, because we don't want to irradiate, we don't want to do bloods if we can get away with it. I mean, bloods are terrible nearly always for most of our pediatric conditions. Blood gas is similar. So really, if we can put a probe on, we can move forward this kind of the narrative, can't we? And that's only going to help further. In a few years' time, I'm sure you'll be able to even answer even more questions, Zach, than we're already doing now.
Yeah, I mean, we've obviously drank from the same Kool-Aid factory, so you and I.
Yeah.
I don't know if that's a term over there.
Well, I'll just have to look up what Kool-Aid is and then agree with you.
Oh
But
my
yeah,
God.
I've heard the expression.
Real quick interlude. There was a cult that it's kind of graphic, but all killed themselves simultaneously by drinking poisoned Kool-Aid. So drinking the Kool-Aid is like, you've bought in, you are a member of the cult.
Yeah.
On that note, so, and I've posed this to PPEC also, and I still debate this, and I kind of go through my own personal ebbs and flows, right? Like, to Dave's point, if I had unlimited time, I kind of would like to ultrasound every child's, heart and chest. I obviously don't do that. And then it's a matter of kind of titrating how often and to whom I'm ultrasounding. I already kind of gave you my feeling about the chest pain patient, but any thoughts from the group? Who do you find yourself scanning? Are we scanning, chests? I'd kind of like to hear some thoughts.
Yeah, I would as well, actually. Someone be brave. Who's doing this in their department? And if so, is that a PEM specific department, or are you doing it under adult guidance more so?
Hi, sorry, I'm Dom. I'm an adult and PEM consultant in London. My PEM team are all pretty novice in terms of ultrasound. That's just because of experience. It's not lack of work. So I'm starting to just train them all up in starting a lung. Then we're going to do a bit of MSK, abdominal. So I've got a lot of wins recently, and they're getting excited about it. So, but it's just getting the flavour for it.
Good man.
And give us are there a couple like chief complaints that you target? Like, how are you kind of, you know what I mean?
It's pretty hit and miss because I only work in PTD on Wednesdays, so it depends what's on the shop floor. But it also depends which other consultant colleagues I'm with. So if they want to focus on lung, we can just practice on any kid with lung because that's just about getting images, isn't it? It doesn't really matter if there's pathology or not. It's getting used to the scanners to start with. And the other thing we're targeting a lot is abdominal scanning because we don't have any pediatric surgery. And if you find it interception, you have no out of hours or pediatric radiologists, it's a quick win as well.
Yeah, sorry, I'm jumping straight in on that one. Definitely, we had a brilliant interception last week, or maybe the week before, and it was just honestly not a story for interception. You wouldn't have thought it. Yeah, every day, like you say, Dom, every day there's the quick wins. I don't know if you've heard that from one of the talks I've given or what, but yeah, that's the kind of language I'll use for it. And yeah, we're just at the infancy. I mean, even you guys, Zach, are still behind your adult colleagues. I always think of you guys will be a few years ahead collectively of what we're doing here, and you've just got to push through, haven't you? And a lot of you, I don't know if this still happens overseas for you guys, but I know what will happen in this country because I hear it all of the time when I present, is that people will be shunned for picking up the machine. You know, they say, "Why are you doing that? What are you scanning for? Why you?" And it's like, well, you bought the ultrasound machine, like you're the, do you know, for God's sake, like, so yeah.
How does it change management? It's like all the residents want to know, what would this change anything that, I try to hark on everything. Yes. Like this is how.
I think, one of the reasons I came to UMass, Dave, in full transparency is, so I was the first PEM, PD person, but they have one of the most established adult programs. So there was a little bit of baseline culture, right? But I just, Pat helped too, but we just trained a fellow who had come from a program with no infrastructure, no PEM person, traumas coming in, not getting fast. So, it's kind of crazy to me in this day and age, the variation that still exists, right? Whereas I think there's, and we're in one place, but there's also programs, we have friends and colleagues at places like Columbia where 8 of the 30 faculty are PEM ultrasound trained, so it's just like the variation that you might hit is just remarkable. But I would say, at UMass, because of the embedded adult culture and then just how annoying and persistent I am, we're not kind of getting the why are you picking that up so much. But there are places, not far from here where that's certainly the case.
Yeah.
Yeah. I mean, me and Patrick put this together last year. It was just kind of like a food for thought because I don't know about you guys, but this is certainly one of my more common, triage complaints, fever and cough. Fever certainly, but almost all those kids have some coughing, right? So, and just thinking about like, again, I can't scan everyone, right? So, we have a huge population of kids with asthma. If they don't have asthma and they have fever and cough and it's for more than a couple of days, I really think that's a kid that you should be thinking about POCUS for. Furthermore, even if they have asthma, if they're not presenting with symptoms of asthma, like, it could be like, the kid with asthma can still get, a pneumonia or pneumothorax, or probably more likely to get a pneumothorax, certainly. So, just kind of bearing that in mind. But I kind of just have this more for myself because I'll go through patterns where, I'm doing, 6 of these a shift, and then I'll go a month without doing many and just trying to find my, like, happy place, if you will. I don't know if, Dave, do you have any reflections on, like, I could come up with a reason to scan every patient. It's just kind of a internal dilemma.
Yeah, look, you can solve this straight away, can't you, to any of the most obstructive of colleagues if you wanted to, by just one sentence. They ask you why you're doing all of this. I could just simply say 4 words. Why do you examine? That's why do you examine? 4 words. Why do you examine? Because we've taken our history, we've got a feel for what's going on, but this is our examination. You're right, I might still occasionally feel a tummy, but increasingly now the probe's going on in the right lower quadrant, So I think it's simple, isn't it? You're right. There's so many patient groups we could look at from a respiratory point of view. We looked at some of our broncholytics, but I don't do it a lot, unless I'm really worried about them. And I bet there's bronchiolitis lung ultrasound scores that exist out there. It's probably one of the areas that is well researched. And yet it's such a ubiquitous presentation, you just treat them, admit them or whatever. But I bet there's a lot of good nuance amongst those groups. We thought about scanning the wheezers to see, who might respond, who might not respond. Are there any features on lung ultrasound there? And I think it's probably one of the areas that will keep moving forward. And I don't know in which direction. I know you and I have been in some of the talks in PPEC when they've talked about the use of color Doppler and the use of kind of power Doppler for different things, looking at collapse versus consolidation. I haven't played around with it like religiously that much to be able to agree. And I know in the call when that came up last year, like a lot of people were a bit, I don't know if we're quite there making big distinctions on massive things, but it's so helpful. It is just for the number of effusions we found 1 year. I think it was, I don't know, anyone in the UK can back up, but I think it was the kind of maybe the year before just gone, and kind of loads of pneumonia and maybe 9-10-year-olds, stuff like that, and just lots of pneumonic effusion.
Yep. Yeah. Yeah, no, exactly. Well, and I was going to say, if you get a drink in Sid Karish, he'll tell you, we should be looking at lung excursion to figure out, who's going to tire out and need increased respiratory support, right? I never, ever do that. But, the possibilities are kind of boundless, I think.
Yeah.
I threw one kind of, do we have time for like just one fun, unrelated case, Dave?
Yeah, you're good. Yeah.
Yeah. Oh, I just threw this in here. The other kind of, and I don't know what terminology you guys are doing in England these days. The idea of like autism, Asperger's, we kind of have, I think the more politically correct term now is neurodivergent. But I've just found these kids will hide stuff. They are running around, going nuts, and will have the most impressive findings. And so this is another one of my push and pulls, right? They're going to be harder to get to sit still for an ultrasound sometimes. But that third kid, the 22-day with the fibrinous consolidation was, like a minimally verbal, autistic child. So I think it's just something I like to think about.
Yeah.
All right. So this is not related to lung ultrasound, but I figured we'll see if our sense of humors match across the pond. So abdominal pain, like Dave, this was a boy, so it's even easier, right? I don't have to worry about ovaries. Anyone want to jump in with any thoughts?
Yeah, there's definitely something where it shouldn't be.
What makes you say that?
Well, as you can see, bladder, I'm looking for rectum. I was thinking, right, I've got stool, and then there's something very cylindrical looking with almost looks like a trachea there. But I'm maybe just jumping straight in on the, you might have made me fall for that one. But yeah, so we've got normal bladder and lung, no free fluid. We've got some bowel gas, posterior acoustic enhancement. But again, I still see, yep.
Can you do it?
Oh, I don't
Yep.
Go backwards.
Yes. I can't go back. All right, we're gonna keep going forward.
Keep going forward, only forward.
But
You were trying to make me doubt myself there, weren't you? But no way.
no, well, the thing I love about it is it looks like I'm just not doing our animation. Yeah, it's what was I gonna say? It looked exactly like what we look for with airway and intubation.
Exactly.
Which I thought was just like like perfect. Oh, here.
Oh, scrolling.
Right? Like, why is there an airway?
I said trachea, didn't I? I said trachea.
Yeah. Why is there what? Wait, what? What term are you using?
Trachea.
No, the trachea.
Oh,
Yeah.
Just trachea.
got it. Yeah. I was like, right. I was like, why is this kid's airway in his butthole?
Definitely. I wonder
Yeah.
if anyone else saw that or not. Maybe, again, I don't know where our group are at, but so using POCUS for intubation, confirming intubation, endotracheal versus bronchial, It's if anyone here is adults or does a bit more anesthetics, it's brilliant for that. Really, really, really quick and easy and good. There's like 3 or 4 signs you look for, one of them being lung slide, a few other different signs. And this would be a good view of what you get for a trachea. I'm sure you'd agree, Liza. Just not down there.
And yeah, it's supposed to have animation, but basically, that's not how you're meant to take care of the smell after you use the restroom. So
very good.
Anyways, it was an absolute pleasure. Thank you for having us, Dave.
Guys, that was amazing. I hope everyone else on the chat agrees. Really good turnout despite the change in time for us as well. So thanks so much for coming along, because I think it's just nice for people to hear different voices, not always kind of from yourself or someone within our sphere. And it's people in PEM, it's the one kind of area where I don't think anyone can argue that what we're doing's really important for the kids, families. We're not just messing about scanning every old person's heart. You know what I mean? I'm not saying that's a problem, but I think for us it's, echoing everybody or whatever. I just think for us it's, we're all trying to put out pieces of work that back up what we're doing, little studies, and it's a game changer every single afternoon, isn't it? Like every day you're at work, it's a game changer.
Absolutely.
And our group are probably just getting into it, some of them, as you heard from other people, but keep attending, and we'll get you guys back, please, next year. Is that all right?
Was that to us, Dave? Sorry.
Yeah, we'll get you back
Yeah,
in
please.
2026.
Yeah. And just Wikipedia, drinking the Kool-Aid. I forget the guy's name, but
I will. I mean, I say have you back in 2026. That's dependent on Trump sort of not doing.
Come on.
That's right. Very good. Thank you all.
Thanks so much, guys. Take care.
All right.